Hi, my name is Marina Margarian, and in this presentation, we are going to explore the theme of sexuality and aging. Sexuality includes aspects of physical, emotional, mental, and social well-being. At the end of this presentation, you will be able to list the myths about older adults and sex, compare the realities of sex in older adulthood throughout the lifespan, identify the various age-related changes, including menopause and andropause, as well as emotional and social barriers that threaten the older adult's ability to remain sexually active. Finally, I will discuss ways in which healthcare professionals can shift the current paradigm and offer constructive learning opportunities in promoting the sexual health of the aging population. Attitudes towards sex have changed over the years, quite drastically, actually. Sex was once a major conversational taboo. However, through education, including courses, workshops, and the help of counselors, there has been a huge shift in giving the public better insight about sex and the enjoyment of sex. The stigma that was once attached to premarital sex has been reduced by the increasing number of unmarried couples living together. Unfortunately, these attitudes have not extended to the older adult. Instead, historical ignorance and prejudice have reappeared. In large, this is due to the lack of education, lack of attention in literature, and lack of open discussions about sex by older adults. Rather, any signs of interest in sex or open discussions about sex by older adults are often mocked, discouraged, or viewed suspiciously. It has almost become a double standard that an unmarried young and middle-aged adult can engage in sex, but not a widowed grandparent. The same criteria that made a man a playboy at 30 years of age now makes him a dirty old man at 70 years of age. These negative attitudes have perpetuated several myths about older adults. Let's look at some of the most common myths out there. And in the slides that follow, I will offer evidence to refute them. Myth number 1, only the young are sexually attractive. Myth number 2, sex causes heart attacks. Myth number 3, there's nothing you can do about normal body changes that interfere with sex and enjoyment. Myth number 4, older adults don't have to worry about sexually transmitted diseases. Myth number 5, women lose desire after menopause. Myth number 6, older men can't achieve an erection. And myth number 7, older adults aren't interested in sex. As with anything, misconceptions carry consequences. And one such consequences and myth about sex and older adults is that older adults may not receive respect as sexual beings. Therefore, there will be a lack of privacy for them, a lack of credit given to their sexuality, and a lack of acceptance in their sexual expression. In a healthcare setting, this can manifest into subtle or blatant violations of respect to older adults' sexual identity, such as the following: belittling older adults' interest in clothing, cosmetics, and hairstyles, Dressing men and women residents of a nursing home in a similar asexual clothing, also known as gender neutral clothing. Denying women's request for a female aide to bathe her. Forgetting to button, zip, or fasten clothing when dressing older persons. Unnecessarily exposing older individuals during examination or care activities, and discussing incontinent episodes when the involved individual's peers are present. Ignoring a man's desire to be cleaned and shaved before his female friend visits. Ignoring attempts by older adults to look attractive. Not considering that an older adult's spouse or partner can be of the same sex. And finally, joking about two senior citizens' interest in and flirtation with each other. These examples demonstrate a lack of understanding that it is important to recognize and respect the sexual identity of any individual, regardless of age. Older adults are just as entitled to the same dignity and respect as sexual beings that are afforded to persons of other ages. Another consequence to the misconceptions about sex and older adults is that issues relating to safe sex are often overlooked. As a result, the incidence of AIDS has increased more than twice as quickly in people over 50 than in younger adults. Additionally, the older adult population accounts for 1 in 6. You heard that right. 1 in 6 HIV and AIDS diagnoses in the US. Other possibilities for the rise in sexually transmitted diseases is that older adults may not consider using a condom because, well, pregnancy is no longer a risk and they themselves have misconceptions about sexually transmitted diseases, believing that it only affects the younger person. And if they do become symptomatic or learn that a sexual partner is HIV positive, older adults may be embarrassed to seek medical attention or may attribute the symptoms to normal aging, like we've seen with many disease progressions. Sexual styles, interest, and expression of the older adult must be viewed in the context of the individual's total life experience. For example, an individual who is disinterested in sex and has had infrequent intercourse throughout their lifetime is not going to suddenly develop a desire for sex in old age. It's just not going to happen. Similarly, a couple who has sustained an interest in sex and had regular intercourse throughout their adult life will most likely not give up this activity just because they are older. Other sexual patterns, such as homosexuality, masturbation, and a desire for a variety of sexual partners, also continues into old age. Although sexual behavior and roles remain fairly consistent throughout the lifespan, sexual identity and expectations can change based on the current social climate. Male and female roles have changed over time. For example, baby boomers changed gender roles when women's liberation movement encouraged them to be independent, strong, and on equal terms with men, both in the home and workplace. And simultaneously, there was an acceptance and almost expectation now that men should share household and family responsibilities. These differences need to be recognized and respected to acknowledge older adult sexual identity, both past and present. Our book, Gerontological Nursing, defines sexuality as such. Sexuality is, for the older adult, much more than physical acts. It includes love, warmth, caring, and sharing between individuals. It is seeing beyond gray hair, wrinkles, and other manifestations of aging. And it includes the intimate exchange of words and touches by sexual beings. Considering the multiple losses many older adults experience, having meaningful relationships can sometimes be more than enough to satisfy intimacy needs. Sexual expression is important, and certain age-related changes impact the older person's sexual function. The following age-related changes can be expected. There is a decrease in sexual responsiveness and a reduction in the frequency of orgasms. Older men are slower to erect and ejaculate. On the other hand, older women may experience painful intercourse due to dryness and thinning of the vaginal walls. And many older women can gain a new interest in sex now that the fear of an unwanted pregnancy is no longer there. Or quite possibly because they have more time and privacy since their children have left and they now have an empty nest. Despite individual differences in age-related changes, regular sexual expression is important in promoting sexual capacity and maintaining sexual function well into older age. One of the greatest and possibly most challenging changes experienced by all women around the 5th decade of life or so is menopause. Menopause, by definition, is a permanent cessation of menses for at least 1 year. Menopause occurs when estrogen levels decline and there's a drop in the number of ovarian follicles, as well as a loss in their ability to respond to gonadotropic hormone stimulation. What are the symptoms associated with menopause, you ask? Well, I'm here to tell you. There is actually a very long list of physical, emotional, and cognitive symptoms that occur during menopause. Physical symptoms include hot flashes, fatigue, new onset of migraines, symptoms of arthritis, fibromyalgia, heart palpitations, atypical angina, restless leg syndrome, vaginal dryness, itchiness, a loss of subcutaneous fat in the labia, insomnia, decreased metabolic rate and weight gain, increased fat on the abdomen and hips, urinary tract symptoms, bladder and vaginal infections, increased risks of osteoporosis, heart disease, and even colon cancer. Emotional and cognitive symptoms include moodiness, depression, memory problems, fuzzy thinking, lack of concentration, lower intolerance for annoyance, quick to anger, greater impatience, anxiety, restlessness, new onset of panic disorder, paranoia, and even psychotic symptoms. The majority of these symptoms are related to the decline of estrogen, and women are truly amazing beings and deserve a gold medal for having to endure them later in life. Fortunately, there are some options for managing menopausal symptoms. The most frequently used is hormone replacement therapy, or HRT for short. As the name implies, hormone replacement therapy is just that. It helps to replace the lost estrogen caused by menopause. There are both risks and benefits to hormone replacement therapy. According to our textbook, Gerontological Nursing, the age at which therapy is initiated is a determinant of the associated risks. For example, women under the age of 60 who began therapy within 10 years of menopause and had no contraindicated conditions had a more favorable risk-benefit ratio. Essentially, they had a lower risk of heart attack and breast cancer, as opposed to women 60 years of age and older who began therapy more than 10 or 20 years from menopause onset. A loss of estrogen can bring about many physical changes and cause women in their 50s, 60s, and beyond to feel unattractive, unappreciated, and underutilized. The fact that Western society tends to prize physical beauty of youth over inner beauty really compounds the effect of menopause. Therefore, it is important to look at this period as a new chapter of creativity and wisdom rather than a loss of youthfulness. Some other complementary and alternative therapies that can be used to offset some of the symptoms of menopause also include acupuncture, diet, exercise, imagery, meditation, regular and adequate sleep, stress management, even Tai Chi, vaginal moisturizing agents, vitamins and minerals, and even yoga. Although highly debated and a somewhat controversial topic, some men do experience a similar hormonal fluctuation when approaching older age that can have an impact on their sexuality. And that is andropause. Andropause is a term used to define the natural decline in testosterone levels, usually beginning around the third decade of life. The one major difference between andropause and menopause is that andropause does not occur in all men. And when it does occur, the process tends to be at a much slower rate. And unlike women whose bodies stop making estrogen after a certain age, the testes don't really lose their ability to make testosterone. Instead, when testosterone levels drop, the body ramps up the production of follicle-stimulating hormone, known as FSH, and luteinizing hormone, known as LH, in an effort to increase testosterone levels. Low levels of testosterone can result in physical as well as emotional and cognitive changes. Physical manifestations include a reduction in muscle mass, energy, strength, stamina, even erectile dysfunction, along with breast enlargement, osteopenia, osteoporosis, shrinkage of the testes, and reduced libido. Furthermore, low testosterone is associated with reduced sexual function and a higher risk for chronic renal disease as well as type 2 diabetes. Andropause is not a normal part of aging. And while androgen replacement therapy is available and a viable option, it does carry potential risks, which may in some instances, or actually in many instances, outweigh the benefits. Therefore, it should be used with extreme caution. In addition to the age-related changes, various physical, emotional, and social variables can threaten the older adult's ability to remain sexually active. Table 31-2 to your right from Gerontological Nursing lists additional nursing problems related to sexuality. Feel free to pause and look over them. Consider this. By the age of 65, there are only 7 men to every 10 women. And by the age of 85, that ratio becomes 1 to 2. Compared to older men, older women are disproportionately affected by partner availability. And this, in large part, is due to older men's tendency to marry younger women. For example, 1/3 of men over the age of 65 have wives younger than 65. It's no surprise then, right, that most older men are married to younger women, while most older women remain widowed. Sexual function can be impaired by psychological causes. These include negative attitudes from society, fear of losing sexual abilities, concerns about body image, relationship issues, and even misconceptions held by older adults themselves. For example, hearing comments about the inappropriateness of older people engaging in sex and watching television shows that portray sex among older individuals in a ridiculing manner may make older adults feel foolish or even unnatural in having sexual desires and activity. Problems can also occur when older adults, specifically older man, believes he is losing his sexual capacity even when he is not. An example of this is when older men will occasionally, have difficulty achieving an erection, which could be from something as simple as an interruption like a ringing telephone or his partner getting out of bed to go to the restroom. That occasional episode can cause anxiety over the permanent loss of sexual function, which further exacerbates and interferes with the ability to have an erection. Body image and self concept also affect sexual activity. A society where youth is beauty can leave an older adult feeling physically unattractive, which can be particularly difficult for a single older person who faces having to bare their naked body to a new partner. These challenges may cause older adults to avoid situations altogether and just remain sexually inactive. How men and women were socialized can also create constraints on relationship status. Older women were socialized during a time when sex was considered appropriate only in a marriage and only for the purposes of procreation. And so the thought of seeking sexual gratification with a partner whom the older person is not married to creates anxiety and guilt. In contrast, older men were socialized to be the aggressor. And unless he's had plenty of opportunities to practice his dating skills over the years, he may feel insecure in his ability to seduce a partner. Or he could be entirely uncomfortable in establishing a new sexual relationship. Even married older people experience problems. For example, some women participated in sex because it was quote unquote a wife's duty, and yet they never achieved satisfaction from that intimate experience. Some spouses may have become bored with having the same partner or form of sex, and even physical changes could cause them dissatisfaction with their partner. Sexual interest could also be lacking if one of the partners is serving the role of a caregiver or if a disability causes a perceived sexual undesirability of a partner. Misconceptions held by older people can serve as self-limiting beliefs and have an impact on sexual function. Some misconceptions held by older adults are that erections are not possible after prostatectomy, or that sexual intercourse can be harmful to a woman after hysterectomy. Another is that menopause eliminates sexual desire, that sex is bad for a heart condition. Intercourse can refracture bones, such as that of the hips. And finally, that sexual ability and interest become lost with age. To you and I, these fallacies can be easy to see through and even somewhat silly. However, for an older person who is already in a vulnerable state, considering the changes they've endured in the lifespan, these misconceptions may seem very factual and give rise to extreme anxieties and fears. Lots of physical conditions can affect sexual function later in life. Here's a list of medical conditions and the problems they create in sexual function, specifically for men. Prostatitis can cause discomfort and interfere with ejaculation. Prostatectomy can also cause disturbed function of the internal sphincter, causing impotency. Infections can cause pain, prevent erections, and cause scarring that narrows the urethra, which is essentially where ejaculate is released from. Infections of the genitalia can also cause pain. Atherosclerosis can lead to declines in male sex hormones. And arthritic changes can cause impotency. And also, Parkinsonism can cause a decrease in sexual interest secondary to the loss of potency. Here is a list of medical conditions that impact women's sexual function. As we've learned previously, menopause is caused by a decrease in the female sex hormone, estrogen, and consequently, this leads to excessive vaginal dryness, making sex painful. Similar to men, genital infections can also result in discomfort and itching in women, making sex feel very uncomfortable. And also, a prolapsed uterus can also cause pain and make intercourse difficult. Not all medical conditions are exclusive to one sex or the other. Here is a list of some of the most common ones affecting both men and women simultaneously. Cardiovascular and respiratory diseases can cause shortness of breath, coughing discomfort, fear of heart attacks or death during sex, as well as decreased libido. Arthritis can limit movement and the extent of sexual acts. Diabetes mellitus can cause genital infections, delayed or decreased vaginal lubrication, and even result in ejaculation failure due to inhibition of the parasympathetic nervous system. And finally, alcoholism can cause impotency in men and delayed orgasms in women. A thorough evaluation is absolutely critical in developing an appropriate intervention. Nurses have the crucial role of communicating the importance of sexual health to their older adult patients. Let's take a closer look at one of the most common physical conditions that impacts an older man's sexual function: erectile dysfunction. Erectile dysfunction is when a man is unable to attain and maintain an erection long enough to engage in sexual intercourse. This condition affects approximately 40% of men between 40 and 70 years of age, and prevalence increases with age. Erectile dysfunction can have multiple causes, including atherosclerosis, diabetes mellitus, hypertension, alcoholism, and psychological factors, to name a few. Quite often, the medications prescribed to older people affect potency, libido, orgasm, and ejaculation. We've seen many of these medications in our patient charts, and few of us have even had the opportunity to administer some of them during our clinical rotations. They include ACE inhibitors, adrenergic blockers, benzodiazepines, antidepressants, antihistamines, antihypertensives, diuretics, dopamine agonists, monoamine oxidase inhibitors, sedatives and hypnotics, and even some recreational drugs. It would probably be a good idea to educate and prepare older adults for the potential changes in sexual functions that these drugs can produce. A final barrier to sexual health is cognitive impairment. The only caveat is that the sexual behavior of the affected person, more often than not, tends to be difficult or more difficult for those around them than for the affected person, or in this case would be the older adult. Cognitive impairments can give rise to inappropriate sexual behaviors, such as masturbating in public places and grabbing or making sexual remarks to complete strangers. The cognitively impaired older adult may even accuse his or her own spouse of improper sexual advances, such as when the spouse sleeps in the same bed, or attempts to provide care procedures such as bathing, or even statements such as, "How's my sweetheart?" or "Are you going to give me a big hug?" can be misconstrued by the cognitively impaired older adult as sexual invitations. The key is to not become upset, whether you are the spouse or the caregiver, and instead redirect and reorient the older adult. So, how can healthcare professionals, specifically nurses, promote healthy sexual function in the clinical setting? Well, one way they could do this would be by extending basic education to older adults and persons of all ages and teach them to understand the effects of the aging process on sexuality. After all, we're all headed in that direction and no one is immune from age-related changes. Education can happen during routine health assessments as part of health education classes and during discharge planning when reviewing activity restrictions. This kind of willingness on behalf of the healthcare professional demonstrates recognition, acceptance, and respect for the older adult's sexuality. The nurse can also identify physical, emotional, and social barriers to the older adult's sexuality and intimacy during discussions of sexual history. Based on these findings, the nurse can then provide solutions and promote practices that can enhance sexual function, including exercise, good nutrition, limited alcohol intake, ample rest, stress management, good hygiene and grooming, and enjoyable foreplay. Nurses can also act as facilitators for older adult sexual relationships. What does that mean exactly? Well, they can teach ways that promote effective expression of inner feelings and help the patient to respect others' expressions of feelings. The nurse can also provide information on sources of social activities, which can be done by obtaining addresses and contact information for local senior centers, clubs, and social organizations, or by suggesting ways in which the older person can expand their personal network, make more friends. Other ways can be by supporting the older patient's efforts to enhance their appearance, listening without judgment when the patient talks about their sexual interests, and finally, refer patients to the appropriate specialists for treatment of conditions that affect sexual function. There are many, many, many more ways that nurses can facilitate this process, and we've only scratched the surface. Malta et al. Took to science to demonstrate the vital role of healthcare professionals, nurses, and doctors alike in sexual health discussions related to older adults. The study investigated the views and experiences of older patients, healthcare professionals, and creators or users of online health surveys. Older adults were recruited through a variety of online and professional sources. The resulting sample consisted of adults ages 60 to 90 plus. Among those were 12 men and 9 women. Each subject was interviewed either face-to-face or by telephone interview over a 5-month period. Interview questions were not specific to the participants' own sexual health or sexual activity. Instead, Malta et al., the researcher, was interested in knowing whether discussions pertaining to sexual health among older adults and their doctors occurred or not, and how each group felt about these conversations. And lastly, their ideas on what types of sexual health tools would be appropriate in facilitating future discussions. The research found that sex was a relevant and very important aspect to all older adult participants. Although definitions of sexual activity had changed throughout the lifespan, the older adults felt that it was still critical for healthcare professionals to understand this and recognize that other forms of sexual expression had taken the place of what once was for sexual intercourse. The study also found that sexual interest was very strong among the older adults, and that most encountered 3 major themes relating to difficulties in opening up dialogue on sexual matters with healthcare professionals. Overall, the older adults felt a sense of discouragement toward sexual discussions, an invalidation of their sexual interest, and a fear of judgment. Surprisingly, when interviewed, the healthcare professionals indicated that they had a preference in allowing the patient to lead discussions, which was a bit counterproductive considering the older adult patients also preferred that the doctors begin these discussions. Although several variables, including but not limited to societal attitudes, psychological and social barriers, cognitive impairments, medications, as well as age-related changes and conditions can impact sexuality in later life, what remains clear is that sexual activity does not get lost with age. Therefore, healthcare professionals have an essential duty to not only promote sexual health and well-being of their older patients, but also a duty to educate patients of all ages about the effects of the aging process on sexuality, so that everyone is better prepared for what is to come in the future. Sharing is caring, and I'd love your thoughts and ideas to any one of the listed questions or any general perceptions on the subject. Please use these questions as a guide and feel free to interact as you wish. I'm really looking forward to reading your questions, your comments, and also your feedback. Thanks for your undivided attention, and most importantly, for tuning in. I hope you enjoyed this presentation and learned valuable information as to how you can promote the sexual health and well-being of your patients in your own nursing practice. If you'd like more information on the topic or just to dive deeper, here are a few resources to get you started. Thank you.